in the same facility as Rachel. Like she said, we have a 17-bed intensive care unit. It's a mixed unit. We get lots of different kinds of patients. My part of the talk is going to focus on smaller facilities, such as primary stroke care centers and acute stroke-ready hospitals. As we know, minutes count when you're talking about the brain, and so you want to get the care to the patient as quickly as possible, as safely as possible. Oops, wrong way. I work in a 150-bed facility in Indiana. We became stroke certified in 2015. We're really proud of that. As it is estimated that up to 40% of the population doesn't live in a reasonable reach of a comprehensive stroke care center. And that's why I feel primary stroke care centers and acute stroke ready centers are a very big important part of the step of getting the medication and the treatment to our stroke patients as early as possible within the 4 hours, especially for TPA, 4.5 hours. Acute stroke ready hospitals are typically small facilities located remotely away from primary stroke care centers and comprehensive stroke care centers. They serve rural communities, and they tend to be, like I said, very small, remote. They usually send out a lot of their patients to bigger facilities. But we feel like if we could reach these smaller facilities and get them acute stroke ready, you can use telemedicine from the bigger facilities to even initiate TPA in their ER, so they can get the door-to-needle times down quite significantly. This is a slide I found on either the Joint Commission or the HVAC website, and I realize that the comprehensive stuff has kind of been cut off, but I'm talking mostly about the acute stroke ready and primary stroke centers. There's not very much difference in between the two, and you can look at that at your convenience. A lot of it has to do with whether the OR is ready, whether the neurosurgeons and neurologists can be on site 24 hours, and things like that. I live in Indiana, and as you can see, I don't know if you all are familiar with the Midwest. This is Indianapolis, obviously the race car, the 500. The only comprehensive stroke care centers in our state are in Indianapolis, right there in the center. If you think about the next closest ones, Chicago is 3 hours from Indianapolis, Cincinnati is 3 hours, and the University of Kentucky is 4 hours. So it could be, if you needed to get access to a comprehensive stroke care center, it could be quite a while if you were in one of those rural settings. Sorry. I highlighted the primary stroke care centers that are certified currently in our state as well, and as you can see, this is kind of like an hour out, 2 hours, and 3 hours. So again, the time can be of the essence, and if you live in these areas here, down here, where it could be a couple hours if you live in here, even to the closest primary stroke care center. And the major roads and the major highways in our state are orange, so these are little backcountry roads, 2 lanes. This is a facility in Crawfordsville, Indiana, and if we go back to this slide, this is Lafayette, and Crawfordsville would be probably around here. It is our sister facility. It's a 30-bed facility, about 45 minutes away from the facility that I work at. Their goal is to be acute stroke ready by the end of 2016, and we're very proud of that. They've already started using their telemedicine unit and have had some success with that, and the learning and the education is in place. This is their telestroke unit. They named her Claire. They're very proud of her. I don't know if you've ever worked with telestroke, but there's a camera, speaker. The neurologist has the program at the hospital and at home on his laptop for 24-hour access. They position the unit in front of the patient, and the neurologist can see the patient and speak to the patient, do the NIH with the assistant of the nurse at the bedside. The physician has the ability to zoom the camera in and out and ask questions. And there are also some headphones here, so he can talk to the nurse privately, or they can, if the patient is having trouble, they can assist them with hearing. This is a case study that we recently had of a patient who came into the Crawfordsville ER, which is the facility I was talking about. He was 54 years old. He complained of right-sided weakness and facial droop. His last known well time was 1 o'clock in the morning. The patient was stroke alerted from the field by the EMS, and that's one of the things that we're working on, is teaching the paramedics and the buses to recognize the signs and symptoms fast, using the FAST scale, and alert the hospitals of these patients that they're coming in. He arrived to the emergency room at 1:19. He got his CAT scan. The turnaround time to results was 38 minutes, and those results are being looked at by the radiologist, as well as a remote radiologist, as well as the neurosurgeon on his laptop, or neurologist, sorry. The lab turnaround time to results was 34 minutes. They completed the telestroke consult at 1:44. The TPA was ordered at 2:04 with the bolus given at 2:09, so the door to needle time was 50 minutes. And by 2:32, the patient's right-sided weakness had improved and his facial droop was resolved. He remained stable and was transferred to another acute care facility, not ours. Yes, ma'am?
And what was his NIH? Is it clear?
Oh, you know what? I don't know what his NIH was. I'm sorry, I didn't put it in. It was probably in the information that she gave me, but.
Probably pretty low. I mean, this patient droop.
Yeah, our neurologists have been looking at the CAT scans and giving them with lower numbers. I don't know. I'd have to ask our doctor what their reasons are behind that, but they've been kind of pretty aggressive. So, anyways, he remained stable and was transferred out. Okay. So as you can see, if you think about that patient and the time limits in my state, he could have been remote, farther outside of Crawfordsville, and it could have taken him longer to get to the hospital, say, half an hour to get to the hospital, maybe, even if he was stroke alerted. And then another half an hour, 45 minutes getting examined, and then if we didn't have the telestroke, they would have to call an ambulance if the ED physician thought he needed TPA, and they didn't want to do it there, which previous to this education, a lot of times the ER physicians in our farther out facilities didn't want to make that decision. So you'd have the 30 to 45 minutes to an hour getting him to our facility, and then us reassessing him and getting the doctor there, and he could be getting really close to the 4.5 hour time frame for TPA. Comprehensive stroke centers totally will completely benefit the most severely affected patients, but and I'm not downsizing the need for those. They're really important because we don't have the capabilities that they do with the endovascular surgery and things like that. But primary care stroke centers have been shown to improve outcomes, and I think that we need to still remain focused on some of the smaller systems, especially acute stroke ready, to get these patients in the outlying and more rural areas. Obviously, our future challenges include improving the EMS triage, getting the paramedics to really look at these patients and let the emergency rooms know that they have a stroke coming in, and increasing rural access, trying to promote acute stroke ready hospitals across the country in the smaller areas, because 40%, that's almost half of our population doesn't live within reasonable access to the upper two stroke centers, so I think that's really important. These are my resources, and our next presenter is Miss Bernie. Thank you.